Welcome to Moments with MamasteFit, where we share a professional experience that we've had as a labor nurse and a doula and how we approached it so that you can learn from us either as the person that is going to be in labor or the person that is supporting that birth. In this episode with Moments of MamasteFit, we're going to be talking about the labor curve. Does everyone dilate at the same rate as each other? Can we plan when babies will be born? We cannot. And so I have one story. Roxanne has a story that's complete opposite. And they both resulted in a baby being born eventually. For me, one of my stories was that my client was like 4 centimeters. She had been checked. And then things really shifted for her in her temperament, where she was in very much a very active labor pattern. And then she felt an urge to push. And about like 30 minutes had passed at this point. And so she was 4 centimeters at like 10 a.m. And then at 10:30, she was like, I feel like I have to poop. And I was like, I don't think it's poop. I think it's your baby. And sure enough, she started pushing. And then 2 pushes later, her baby was born. But how did she go from 4 to baby in less than an hour? Like, I thought you're supposed to dilate 1 centimeter at a time. And so that is like my example of how dilation can really just mean nothing. Like, you can go from 4 to baby in less than an hour.
So I recently supported a birth where they dilated every 4 hours, 1 centimeter. So 1 centimeter every 4 hours. For Gina's entire labor, she dilated 1 centimeter. And that was her labor curve. And that was completely normal and completely fine because we all have our own labor curves. And so to describe what is the labor curve that we're even talking about. So there are 2 main approaches of the labor curves. There's Freedman's curve, which was created in the 1950s. It's 2024 now. 1950s, where they describe one, active labor starts at like 3 centimeters. People are walking around in active labor at 3 centimeters. And then 2, people will dilate at 1.2 centimeters an hour if you have never had a baby before, and 1.5 centimeters an hour if you've had a baby before, once you reach that active labor. So once you hit 3 centimeters, you had to expect like 7-ish hours less until you meet your baby.
And I've heard this curve referenced
Still
in
to this
hospital
day.
settings where they're like, you're supposed to dilate in a centimeter an hour. And if you don't do that, we need to intervene and we need to do things to help you dilate faster.
And this is why people were also being admitted to hospitals at 3 centimeters, because they're like, well, you're in active labor. It's time to have a baby, which that is a whole nother episode, early admission. Okay, talk about that for a whole episode. But the other curve, so this was backed up by evidence. There is evidence that like in the 1950s, they did a study and this was a labor curve in 1950s. But again, it's 2024 now. They did a study like closer to 2024, and this is the modern contemporary labor curve. And this is one, active labor for most of us doesn't start till 6 centimeters. But there are other things that we can look for. Like some people will enter active labor a little bit earlier than 6 centimeters and some after 6 centimeters, but you also have to look at what is their temperament, what is their labor pattern, like the contraction pattern and the intensity of those contractions as well. Like temperament and contraction pattern are 2 really great indicators of labor stage and labor progress. When you go from like talking to us and smiling with us and to like being in your own zone, that is probably the best indicator of active labor. But because science needs numbers, can't use temperament as a scientific thing.
How do you quantify
They found
mood?
6 centimeters to be the average for most people. 3 centimeters versus 6 centimeters. That's a huge difference in centimeters. That could be the difference of admitting someone 12 hours early or even sometimes 24 hours early. Like that is a huge difference between the 2 in like being in the hospital. And then the contemporary labor curve does say once you hit active labor, it does progress like around 1-ish centimeters an hour. And if it is a little bit longer, then there could be an issue. But you have to hit active labor first. And knowing that 6 centimeters on average is it, but some people won't hit it till they're like 7 centimeters or 8 centimeters. One time, we had a patient at another hospital that walked around. She was 6 centimeters. They checked her in the clinic. Because she's like, yeah, I lost my mucus plug. She was like 39 weeks. And they're like, do you want to check your cervix? And she's like, yeah. They called us. They're like, oh, she's coming down just to like monitor because she's 6 centimeters, but feels nothing. She was sent home because she was not in labor. And she's like, I want an unmedicated birth. Like, that's fine. Like, baby's fine. I'm fine. I'll just go home. She was still pregnant for like 2 more weeks.
One of our friends was
6
like
centimeters.
7 or 8 centimeters just walking around, waiting for her baby to be born.
So like, if we just were like 6 centimeters is active labor, she needs to be admitted. And then she would have got Pitocin. They would have broke her water. They would have done everything to put her into labor when she was fine. She was not in labor. She was just walking around at 6 centimeters. Some people, that is just what their body does. 7, 8 centimeters, just walk around waiting to have a baby.
So it sounds like dilation is just a moment in time. So with both of these patients, clients of ours, they were at a certain dilation, and then at some point they had a baby. And the time frame really varied between the two of them, but neither of them had a dysfunctional labor. Like there was nothing wrong with their labor or that labor curve that they were on. And so it's important when we have a cervical exam or we know a dilation that we understand that it's just one piece of the puzzle, one piece of information that we have, and we don't make concrete plans on what that means. And so like we had a nurse delivery for that birth because the nurse, I think she was newer, did not know that babies can come that quickly. And so she casually walked in when I was like, she's pushing guys, and was like, well, I need to check you to make sure that you're ready. And I was like, the baby's head is out.
She's crowning.
Is the doctor going to get paid for this? Like, I guess I wonder how that works. I'm like, who gets paid for that birth?
Whoever delivers the placenta.
Oh, okay. That's interesting. I'll keep that in mind for when I have bills to pay. Just kidding. I'm not delivering any babies.
No, you wouldn't get paid.
I would not get paid.
They wouldn't get paid if they didn't deliver the placenta. I don't think they get paid.
That's interesting. Anyway, so the baby was born before the doctor came in.
I would have gotten at least 3 delivery pays if so, because I've delivered 3 different babies.
I know.
Or caught 3 different babies. I didn't deliver them.
So the baby was born before the doctor made it into the room because of a misunderstanding of how concrete the labor timeline or the labor curve was. And so things that we can look for besides just dilation, because it is just one piece of this very large puzzle, and it's not a predicting tool, is what is their temperament. I find that to be a much better gauge on where is someone in this timeline, and then their movement patterns if they are unmedicated. Like this only works if they're unmedicated. And so what we're looking for, if somebody is like, and I guess this doesn't always work, but if someone's just having a conversation with you like we are right now, they are probably not in active labor. Like if they're just chit-chatting, they may like kind of get into the zone during a contraction, but then they return to the space. They return and they can have like a full-blown conversation with you. They're probably still in like early labor, early active labor. And they may be like 4 or 5 centimeters at this point. There's going to be a shift for 90% of people. Again, we're all individuals. 90% of people are going to make this shift to active labor where they are vocalizing a little bit more. They need more support with their contractions, and they're kind of just like in the zone. Like they don't want to interact with their environment. They can, if you ask them a question, they can interact, but they don't want to. They are good where they're at. They're moving a lot more, they're vocalizing a lot more. So there's a really big shift when somebody makes it to active labor. And for me, it does not matter what dilation they are. If they have made that shift and their temperament is active labor, they're active labor to me. I don't care if they're 2 centimeters. Like that is just their labor timeline. And 6 centimeters does not always mean active labor. The other thing that I'm looking for to let me know that my client is getting close to pushing is there's specific movements that I notice when somebody is nearing the end. So then if they start saying, I feel like I have to poop, or I feel pressure, or I feel like I'm pushing, I'm not going to dismiss it and be like, but you were only 4 centimeters 10 minutes ago. I'm going to be like, get the doctor in here. And so the movement patterns that I'm looking for is they start doing these little like quarter squats where they're like just doing these like really mini squats with their contractions, like maybe not even a quarter of the way, but it's these tiny little squats where they're just kind of like hopping up and down with it. And they start getting on their tippy toes and they start really shifting deep into each hip. So it's kind of like one of those 3 or all 3 of those movements.
Or they'll do a tippy-toed lungy squat from side to side really slowly.
Yeah. So it's like they're up on their tippy toes, they're doing this mini squat, and they're shifting from hip to hip and like really like sinking into each hip. Those are all signs to me that they're trying to create space in the bottom part of their pelvis because baby is very low. And they usually will say, I feel like I have to poop while doing all of those things. For me, I don't like, you're probably good. You are probably dilated as much as you need to be dilated. This baby is coming. We should make sure the table is ready or whatever other thing that you need to be ready to go. And then if they're like, I'm pushing, I'm like hitting a call bell. I'm like, hello, we have a baby being born. I don't want a doula delivery. So those are kind of the things that like I am looking for to let me know that my client is progressing, is they have shifted their temperament to active labor, because I'm not doing cervical exams and they also mean nothing to me. And I'm monitoring their movement pattern. And so I'm seeing these like mini squats, these movements that are telling me that that baby is low. And then I'm listening to their feedback on what they feel. I feel it more in my hips now. The sensation is different. I feel more pressure. I feel like I have to poop. Like those are all things to me that like, we're going to have a baby soon. And it really doesn't matter how long it's been since their last cervical exam or what their dilation was at that point. Those things are better clues to me that a baby is coming. And now what can somebody look for if they have an epidural though, to say that baby is probably really low and we're probably going to have a baby soon, because they don't have the same movement patterns and the same temperament than somebody who's in active labor.
So if someone has an epidural, obviously they can't go based off of their temperament as much, because your body isn't responding to the same stress hormones that you are when you're navigating through contractions. So you don't have the same temperament change, I notice, with an epidural in place, as well as you're not obviously having the different sensation changes as your baby progresses, but it might increase the amount of pressure you're feeling as baby navigates through the bottom portion of your pelvis, because sometimes the epidural is just not as strong near the bottom, where you may not have felt any pressure when baby was a little bit higher up, but as baby navigates through that lower portion of the mid pelvis to the outlet, you might start noticing more pressure. And this is not pain. This is just a change in sensation of pressure, but it should not be painful. That might mean that your epidural might not be working. But if you're starting to, again, feel some pressure in your butt or your vagina, that could be baby is coming down further. The other two things, when you have an epidural, you're going to be continuously fetal monitored. It's just part of the game, because it is something that we're putting into your body that's not normally there, that could affect the way you or baby is handling the contractions. So continuous fetal monitoring is just the golden standard when you have an epidural. So we can monitor baby, though, when you have the epidural, for two things. And these are two things that I look for that I'm like, she's going to have a baby soon. One, early decelerations. And if you're watching the YouTube video, I'm going to put a little picture of what it looks like right here. It is your contraction happens, and then the baby's heart rate will decrease almost like an upside down hat directly over the contraction. So at the start of the contraction, your baby's heart rate will start to decrease, and at the end of the contraction, it'll come back up. But that does not happen after the start of the contraction has already happened, or like it's not quick and like abrupt decrease and right back up. It is like a little upside down hat. Is the best description. And if you're watching the YouTube again, there will be a picture right here of that early deceleration. This is a benign deceleration. It happens as baby's navigating through the pelvis. If your head was being squished and your body was being squished, you would have the same response by your heart rate decreasing. Their head is getting squished as they're navigating through the pelvis. It is normal, and it's kind of expected that at some point maybe their heart rate will go down a little bit with the contractions. Not every baby will do it, but most babies will do it. And again, this is an early deceleration. It's benign. It's a sign to me that, oh, baby's lower in the pelvis. Baby's probably going to be born soon. Sometimes it happens earlier on. It can happen as early as like 4 or 5 centimeters, we've noticed based off of research. But most of the time it's at the end of labor that baby's head's getting squished. The second one, though, disappearing baby. If my heart rate is not staying on the monitor, your baby is probably so low. And that is why. I've had this happen twice where my baby started coming off. So I was like, let me go in there. And I go in there and the baby's crowning. And they felt nothing because they had an epidural. And they're just like, I was like, I'm just coming in here because your monitor is doing something funny. And the first time it happened to me, me and the midwife went in together, thankfully. And the baby's like, friggin' eyebrows were there. The entire family was sitting on the couch. And we just went in there, and she had a peanut ball between her legs. And I was just like, doo-doo-doo, put my gloves on, took the peanut ball out, lifted her leg, saw eyebrows. And I'm just like, midwife, and she's putting on her glove, and the baby delivered. She still had like her Foley catheter in, like her son was there, and I was just like, oh. Everyone was like, oh, the baby's here. She was like, what do you mean? my baby fell. I didn't feel anything. She had to push for a really long time with her first one. And so she's like, wait, what do you mean my baby's out? Like heard the cry.
Literally fell out.
Literally fell out. Everyone in the room was just like, what, the baby's here? We were just talking about what? Like she was in shock of like, that's it? That was the moment? I was like, wow, how amazing. Disappearing baby on the monitor. Those are the things that I look for as a nurse. Early decelerations, disappearing babies, heart rate on the monitor. And then the last thing would be different sensations that you're experiencing. So if you felt nothing, your epidural was great, and all of a sudden now you're feeling pressure in your butt or even sometimes in the back, okay, things are probably progressing, and that's why baby's putting pressure on different nerve endings that maybe the epidural wasn't fully capturing, and that's why you're feeling this increased pressure. We can take it away if you don't want to feel it, but that is a good sign to me.
So there are definitely other signs that we can look at to determine labor progress, because everyone is on a different curve, and so nobody is really dilating at 1 centimeter an hour as individuals. Maybe someone else.
Some people are, because like studies support it.
But most people are kind of all over the place. And so just because you're 4 centimeters or somebody that you're supporting is 4 centimeters does not mean that you have 6 hours left of labor. They can also be 9 centimeters, and it doesn't mean that your baby's going to be born soon. You could still have 6 hours left of labor. And so dilation is just a moment in time, and it's just one piece of the overall puzzle. There's so many other tools that we can utilize to help assess, is labor progressing normally, or is there an issue that we need to address? And in future episodes of Moments with MamasteFit, we will talk about specific issues that we've had during labor, supporting it as a nurse and a doula, and how we solve those issues. But today, just know that labor is magic, time is magic, and it will progress at the level it needs to progress, and it can be faster or slower, but if we don't notice an issue, that doesn't mean that anything's wrong. And so if you want more support during your pregnancy, check out our online prenatal fitness programs and childbirth education course. Our prenatal fitness programs are going to help you to feel confident as you move your body throughout your pregnancy, plus movements to help you move more easily during labor with pelvic floor release exercises, hip mobility exercises, and just tons of birth preparation work. Our childbirth education course is going to help educate you on what to do when you actually are in labor. What labor positions should we do? What is a cervical exam? What type of information are we gathering from that? Because again, it's more than just dilation. There's also effacement and station, and like how soft is the cervix? What position is it in? And so there's a lot of information that we can learn, and we teach it to you in our online course. If you're postpartum, check out our online postpartum fitness programs where we guide you through that rehab process to rebuild, to reconnect so that you can meet the demands of motherhood. And check out all of our other education courses from our postpartum prep course, our newborn course, and our professional courses, which we are going to be updating with pelvic floor PTs this year. So stay tuned for that in the summer timeframe. So if you're a professional and you are like, I want to learn more than just these moments with MamasteFit, I want to learn eon with MamasteFit, check out our professional courses as well. And so you can use code MOMENTS10 to get 10% off any of our online offerings.